Hello, my name is Laura Muiño. I am a pediatric cardiologist at the Ghent University Hospital, and it's my pleasure to present to you the new recommendations for follow-up and management of aortic disease in children with heritable thoracic aortic diseases. And as you know, children are not small adults. And while we have really good guidelines for treatment of adults with aortic diseases, and while many of the information contained in those guidelines are useful for children, I think that children deserve some specific considerations and also some specific recommendations. And that is a reason why these two guidelines have been published this last summer. The first is actually a document which has been, it's a joint statement from the pediatric subgroup of the European Reference Network of Vascular Diseases and the Association for European Pediatric and Congenital Cardiology. And this is a document which is mainly focused on children with FBN1 related Marfan syndrome. The second document that I will like to present today is an American document from the American Heart Association, and it contains information not only relevant for children with FBN1 related aortic diseases, but actually it contains information for all the other genes which are involved in heritable thoracic aortic diseases. And I will be starting with the European document focusing on Marfan syndrome. This document was divided in 4 main topics, as you can see here in this graphical abstract. The first topic was imaging, the second topic was medical treatment, the third topic surgical treatment, and the last topic was sport recommendation and physical activity in general. For the first part around imaging, what this document tries to highlight is the importance of echocardiography as a basis for imaging. As you know, imaging of the distal part of the aorta in adults is somewhat challenging. It's sometimes difficult to visualize the whole aorta, but luckily for us as pediatric cardiologists, that's not the case for children. And the visualization of the distal sides of the aorta in children is feasible, and usually you get very good visualization of these sides. Which makes the use of CT and MRI for children as a secondary option. And is usually only left for either older children, so adolescents, or for those children in which, due to lung problems, due to pectus deformity, the visualization of the distal sides through echocardiography is not possible. As you know, for Marfan syndrome, the visualization of the first part of the aorta, the proximal part of the aorta, is the most important, because that's the site where usually you can find aortic dilatation. And as you can see in this image, on image A and B, there are 2 ways of measuring the aorta, in systole using the inner to inner method, or in diastole using the leading edge to leading edge method. Both are good. The correlation between both measurements is quite high, although the second one, so the diastole leading edge to leading edge, normally leads to a absolute measure which is slightly higher, 1 or 2 millimeters higher than when the aorta is measured in systole. What is highlighted in these recommendations is not so much the method which should be used, but the usage of the correct set scores. So as you know, there have been set scores which have been developed based on measurements in systole. The most known or the most used is the Lopez method. And there are set scores which have been developed based on measurements done in diastole. Probably the most commonly used at this moment is the Campen's set scores, One of the advantages of the Kampen-Set score in comparison to earlier used methods like the Devereux is that Kampens included both children and adults, and therefore the use of these set scores allows for a continuation in the measurement when the children is transferred to an adult clinic. What is also highlighted in these recommendations is that regardless of the method used for measurement, regardless of the set score used for calculating the set score, the most important thing obviously is systematically using the same method in order to be able to compare measurements from year to year. Regarding the frequency, it is recommended to perform an echocardiography yearly in most of the patients with Marfan syndrome. Those children who have a large aorta, so a set score above 5 or an absolute diameter about 45 millimeters, those children in which there is a large aortic growth, which has been defined as an aorta which grows more than one set score in a year, or sometimes during the titration of the medication, we have recommended to perform this echocardiography at least every 6 months. The second part of these recommendations is a medical treatment, and medical treatment should be started at least when there is aortic dilatation, which has been defined as a set score above 2. Considering treatment before a set score of 2 is possible in some cases when there is, for example, very severe family history, in some children with more severe variants, for example, affecting the neonatal region, sometimes variants which cause an haploinsufficiency might have a more severe cardiovascular features. So in those children, starting therapy earlier might be considered, but obviously it needs to be considered as an individual case, case per case, and it needs to be discussed with the parents and with the child if the child is old enough to be able to give his or her opinion. There are different types of drugs which can be used. Beta blockers and angiotensin receptor blockers are the most important, and actually they are equally effective. So depending on the preference of the doctor itself, depending on the preference of the patient, the one or the other can be used in an equally effective way. Most important is to titrate these medications to the maximum tolerated doses, and that will be very dependent on each child. Whenever there is a aortic dilatation above set score, combination therapy, so that means the use of a beta blocker and angiotensin receptor blocker, should also be considered. In these recommendations, there is also a part on the use of psychotropic drugs. Why is that? Because the presence of attention deficit disorder, of hyperactivity disorder, is quite common in children with Marfan syndrome, and that's why there is a part which is specifically gives some recommendation on how to use the psychotropic drugs. In general, these drugs can be used in patients with Marfan syndrome, but when these drugs are started, the control of the heart rate and the blood pressure should be done in a regular way, either by the cardiologist itself or by the general practitioner. And in case that there is an increase in the blood pressure or an important increase in the heart rate, then maybe the non-stimulant drugs should be considered. Regarding the surgical treatment, the different surgical techniques are described in this document, and the recommendations for children are similar to those of adults. So the surgery threshold for children is also 50 millimeters, as it is in adults with Marfan syndrome, but of course 45 millimeters needs to be considered as a threshold in certain circumstances, like for example a family history of aortic dissection, rapid annual aortic growth rate, or for example if a concomitant valve surgery is required, which is something which is more common in children than it is in adult patients. Regarding the sport recommendation, I think that one of the most important aspects is that stimulated physical activity in children with Marfan syndrome is very important, because through physical activity, some other cardiovascular problems like hypertension, hypercholesterolemia in the future will be avoided, or at least will be decreased. And it is important to stimulate this physical activity from a very young age, but obviously the physical activity needs to be adapted to a specific patient. And to adapt this physical activity, there are 5 aspects which need to be taken into consideration. One is the age of the child. So there are different considerations when a child is young, and we talk about children under the age of 10, or when children are adolescents. Why is that? It's because the response of blood pressure to physical activity is different in younger children or in adult children. Another aspect which needs to be taken into consideration is the degree of aortic dilatation, the type of sport, the intensity and the frequency of the sports, as you can see here in this picture. In general, the competition sports should be avoided, except for those low intensity skill sports, like as you can see here marked in blue. The power sports should also be avoided, because they cause a rapid increase in blood pressure. And in general, practice skills, mixed and endurance sports can be performed at a moderate intensity. And I would like to highlight the fact that competitive sports are defined as sports which are performed 6 to 10 hours per week, while recreational activities or leisure activities are those who are performed 4 to 5 hours a week. So, for example, a child who plays football in a low competitive way, where it trains 2 to 3 times a week and might play a match in the weekend, is allowed to do this type of activity, because this is considered a moderate intensity sport. The second document that we will discuss today is the American document on cardiovascular management of aortopathy in children. And this is the document who contains not only recommendations for Marfan syndrome, like the previous one, but also recommendations for all other genes. This is a more complex document which is divided in general concepts, like when to evaluate a child with a suspected aortopathy, imaging consideration, when to perform genetic testing, and like the previous document, some considerations on medical therapy, on surgical therapy, and on exercise and activity. Furthermore, this document contains specific recommendations for each of the diseases listed in this slide. I will just go through the most important parts of this document, and I think that this is one of the very interesting graphs. And this graph summarizes their recommendations on when to perform genetic testing. As you can see, genetic testing is going to be performed in children depending at a different moment, depending on whether they have a bicuspid aortic valve or they do not have a bicuspid aortic valve. In general, in those children without a bicuspid aortic valve, genetic testing should be considered when they have a personal history of aortic of arterial dissection, when there is aortic root dilatation, when there are clinical features which could be compatible with a syndromic form of thoracic aortic disease, or when there is a first-degree family member with a aortic disease or a suspicion of a syndromic form of thoracic aortic disease. In those children with bicuspid aortic valve, the recommendations are similar, and the main difference is the aortic dilatation, while in children without a bicuspid aortic valve, genetic testing might be considered from a set score of 2. In those children with a bicuspid aortic valve, genetic testing may be considered dependent of the circumstances when the aortic root has a set score above 3.5 or the ascending aorta a set score above 5. The American recommendations have very similar guidelines regarding imaging, so echocardiography is also regarded as the most important way of imaging the aorta in children with aortic diseases, with aortopathies, and the frequency on imaging will depend first of all on the severity of the dilatation, and second of all on the gene affected. Regarding the severity of the dilatation, there is a difference in the definition of severity on whether children are under the age of 16, where the set scores are important. So dilatation, for example, is defined as a set score above 2, and depending on the set score, it might be divided in mild, moderate, or severe dilatation. When a child reaches the age of 16, then the dilatation and the severity of dilatation is no longer based on the set score, but is actually based on the absolute diameter, in which dilatation is defined from an absolute diameter of 35 millimeters. These American guidelines they recommend measuring the aorta in systole using the inner to inner method, and the most used set scores in America are the Boston set scores. There is also a part where there is a specific recommendation on when to start treatment. Just like the European guidelines, the American guidelines, they recommend starting either a beta blocker or an ARB. And when to start the beta blocker or the ARB or the combination of both will depend, first of all, on the severity of the aortic dilatation, and second on the gene, as you can see here in this table. Consistently with the European guidelines, the American guidelines in general recommend to start therapy when the diameter of the aorta is enlarged, so when there is a set score above 2 or an aortic diameter of 35 millimeters. And before it can be considered in certain specific circumstances. Exercise and physical activity is also should also be stimulated, and just like with the European guidelines, the level of the physical activity will be dependent on age, will be depending on the different types of physical activity, and will be dependent on the intensity that a child wishes to perform that type of sport or type of physical activity. Finally, regarding the surgical thresholds, the American guidelines actually also recommend the same thresholds as in adults. So that is depending on the gene. For example, for Marfan syndrome, the threshold is also 50 millimeters. But for example, for children affected with genetic pathogenic variant in the TGF-beta receptor 1 or 2 or TGF-beta 2, the recommendation is 45 millimeters. In some specific cases, the threshold might be lower, a little bit following the same ideas as the European guidelines. Maybe one difference to highlight is that in these American guidelines, depending on the age of the patient, the surgical threshold can be decreased severely. So for example, for Marfan syndrome, if a child is under the age of 2 and has a diameter of 34 millimeters, then surgery should be considered. In children between 2 and 5 millimeters, surgery can be considered from 38 millimeters, and above the age of 5 years, surgery might be considered above a diameter of 40 millimeters. And with this, we have come to the end of the presentation. I hope this has been useful. I would like to thank you for listening to this video. And if you would like to ask me directly questions, please do not hesitate. Thank you so much.